Good evening, everyone, and thanks for joining us. I'm Kelly Cleary, Content and Programming Manager at Best Doctors, and I'll be your host tonight. I first need to tell you that Best Doctors is proud to be accredited by the Accreditation Council for Continuing Medical Education to provide 0.75 AMA PRA Category 1 credits for your viewing the webinar this evening. Please take a look at this disclosure information that we have in front of you right now, and stay tuned until the end of the webinar to hear how you can claim your credit. We're very excited to have an excellent panel of Best Doctors for you tonight, discussing their own errors in diagnosing abdominal pain and how you can avoid the same errors. But before I introduce the panel, I'd like to say a couple of words about Best Doctors and how we're working to improve diagnostic accuracy and physician communication. You need to know 3 things about Best Doctors tonight. Best Doctors provides medical consultations or second opinions through a unique and collaborative analytical process. If you're an elected Best Doctor, you're invited to consult on cases and earn an honorarium. And number 3, we're also holding a free pilot program for any physician who would like to initiate collaborations on complex cases in their own practice through our online physician portal. If you'd like to get involved with Best Doctors by providing for virtual second opinions on interesting cases or to hear more about the physician portal that I just described, please indicate your interest in the post-event survey that we'll have at the close of this webinar. And you can also email physicians@bestdoctors.com or visit the physician portal at physicians.bestdoctors.com. And one final bit of housekeeping. If you do have questions during tonight's webinar, please submit those through the Q&A module on the bottom right of your screen, and we'll do our best to address those at the end of the session. And now I'm very happy to introduce Dr. Martin Samuels, our moderator for the evening, who will also be acting as our neurologist on the panel. Dr. Samuels is the chairman of the Department of Neurology at Brigham and Women's Hospital and professor of neurology at Harvard Medical School. A leading authority on the relationships between neurology and the rest of medicine, he has notably linked the nervous system with cardiac function, highlighting the mechanisms and prevention of neurogenic cardiac disease. Marty, thanks for joining us.
Kelly, thanks very much. It's nice to be back. We've had now a series of these very interesting webinars on common problems where errors have been made, and I think we've had quite a bit of fun talking about these cases. I want to introduce a couple of distinguished panelists, both of whom are my colleagues at the Brigham. The first is Deepak Bhatt, who is Chief of Cardiology at the VA Boston Healthcare System and Director of the Integrated Interventional Cardiovascular Program at Brigham Women's Hospital and the VA Boston Healthcare System. He's a senior investigator in the thrombosis myocardial infarction, or the TIMI, study group and professor of medicine at Harvard Medical School. Dr. Bhatt's research interests include preventive cardiology as well as the optimal management of patients with acute coronary syndromes. He also has research interests in advanced techniques in cardiac, cerebral, and peripheral intervention. He's authored or co-authored over 500 publications. Deepak, welcome to our webinar tonight.
Thank you. Great to be here, Marty.
Let me introduce another one of my colleagues, Norton Greenberger, who is a senior attending physician in the gastroenterology division at the Brigham Women's Hospital and clinical professor of medicine at Harvard Medical School. Dr. Greenberger is one of the most distinguished internists in the United States. He's past president of the American Gastroenterological Association and past president of the American College of Physicians and the Central Society for Clinical Research and the Association of Professors of Medicine. He's also past chair for many years of the University of Kansas Department of Medicine. He's the author or co-author of more than 230 publications, including chapters in major medical texts. His clinical research interest focuses on gastroesophageal reflux disease, inflammatory bowel disease, alcoholic liver disease, hepatitis C, and acute and chronic pancreatic disease. In other words, Norty really does all of gastroenterology, and it really is an honor and a privilege to have you with us today, too, Norty. Welcome.
Thank you very much.
I should say as an aside that I don't know if the listeners realize this, but all 3 of us have a strong Cleveland connection. Either way, we're all talking from Boston tonight. We're all at the Brigham. Deepak was at the Cleveland Clinic before we managed to recruit him to Boston. and Norton Greenberger are actually graduates of the same high school, and just a couple of years apart. You're going to have to guess which one of us graduated more recently, but I can tell you that I just came from my 50th reunion this past weekend, Norty. So these are Clevelanders who have been replanted here in Boston today. So I'm going to start with a abdominal pain case that I was referred. And Kelly's going to show you some slides that summarize this patient. This is a very memorable patient for me. I'm going to spend at most about 10 minutes on this, and so we'll have about 15 minutes for each of our three panelists to present one of their own cases. So this is a 37-year-old guy in good health who developed left lower quadrant abdominal pain, and he had this for about 6 months. The pain radiated from the left flank, down the inguinal ligament, and into the left testicle. It was usually not present when he awoke in the morning, but it worsened every day as the day progressed. He noticed something very interesting, I thought, which is that jogging greatly worsened the pain. Any reaction from Norty, or particularly Norty, about what you're thinking at this point?
Well, the left lower quadrant pain raises the question of diverticular disease, even in the absence of diverticulitis. It can also give you pain that radiates to the left lower quadrant and left groin. The jogging, I can't make a connection about that unless it's something local, either in the distal abdomen or the upper thigh.
Thanks. Let's go to the next slide. I'll tell you what happened next. So this is so I was referred him because, as you'll hear in a minute, he'd already had a little bit of a workup by his primary care doctor, and this was my exam. So Norty, you have to bear with me. This is a neurologist's exam of the abdomen. Here we have, at least I'm a former internist. The abdomen was not tender. There were no masses that I could feel. His liver was of normal size. His spleen was not palpable. I couldn't hear any bruise over the abdomen. There was a well-healed appendectomy incision, which he told me was done many years before, at the age of 23. It was a fairly prominent scar that was really, I call it, an evident cicatrix there. He was sort of a person who formed scars. There was a little numbness right around the incision. His rectal exam was normal. His WAC was negative. Next slide. So I and a lot of people thought that, a lot of other people thought that this was a referred pain from renal disease, renal colic of some kind, radiating down the flank, down the inguinal ligament into the left testicle. He had a renal ultrasound, which was normal. He had repeated urinalyses. There was never any blood in his urine, and then he underwent an abdominal and pelvic CT scan, which was also normal. So Kelly put the next slide up so quickly that I think people saw something that was rather interesting, but I wonder if either of you have any reaction to this case at this point. I mean, do you think that this is consistent with a renal cause, as many people did, despite the fact that the renal ultrasound, the abdominal, pelvic CT were all normal? There was no blood in his urine on multiple attempts, or do you think really it's something else?
If you palpated in his groin and his inguinal ligament, was that tender or painful?
It was not. It was not tender. He, as I said, he was a little bit numb. He had a numb sensation and reduced thermal and pin sensation right around the scar, but that was all. Well, go ahead, Norty. You were going to say something.
Oh, no, I was just going to say, did someone do a testicular exam?
Yes, I actually did a testicular exam for what it's worth, and his testicles felt of normal size. They weren't tender. The epididymis wasn't tender, and that's about the level of my ability with testicular exam.
That's pretty good.
So the next slide. So I thought, well, it's numb around the incision. I'll just inject this thing with lidocaine and see what happens, because I do this with other nerve things. And so I injected it, and it was gone. Pain was gone. And the guy was able to jog in place and didn't get the pain. And as the lidocaine wore off, the pain came back. So at this point, it began to become clear to me that we had been on the wrong track, and I obtained a consultation, which is really one of the morals of the story. that I wanted to transmit here today with regard to error, which is that there are people who are really specialized in certain areas of medicine. And even if you consider yourself a pretty darn good generalist and good internist, it can be hard. So I referred him, and I won't go too much further because I don't want to go past the 7:15 with this. And I'll have Kelly show you the next slide. So I sent him to a neuromuscular specialist in the department who actually instantly recognized what this was. He said, oh yeah, this is just an iliohypogastric nerve entrapment. It's entrapped in that cicatrix. And all we have to do is ask the surgeons to open that incision up. They'll find the nerve entrapped in the scar, and they'll resolve it, and they'll take it out, and that'll be that. And so we asked the surgeons to have a look at it. Lo and behold, the iliohypogastric nerve was entrapped in the cicatrix. And what happened is when he ran or stood, it actually put traction on the iliohypogastric nerve. And to just give you the sort of the bottom line on this, sort of the lessons, this nerve arises from T12 and L1. So this pain, which imitated renal colic, is actually radiated pain in the distribution of this T12L1 nerve. Next slide. And I borrowed a couple of pictures here to show you what this nerve does, and you can see that it comes out along the inguinal ligament that comes right across. This is actually showing the opposite side from the one that was involved in ours, of course. Ours is on the left. If there's a scar in the lower quadrant, it can entrap this nerve, and that ordinarily will produce pain and numbness in the distribution of this nerve, and then radiate back to the origin of the nerve, back up into the flank. And the next slide shows you where the injections can be made. So you can see the injection site for the iliohypogastric nerve is right at the anterior iliac crest. And sometimes that'll work. You can inject it with lidocaine or steroids like you would with any other nerve entrapment. Sometimes that'll help. And it did help, and it was diagnostic, but it didn't last. And it came back, so it required a surgical intervention. Next slide. So I think that's the end of that one. So I'm going to turn to Norty in a second, but I just want to sort of make a final statement about this and see if there's any other reactions about this. I want to just warn people that, there's nobody except these neuromuscular specialists who actually know the distribution of all these nerves. I mean, I'm a general neurologist. I consider myself pretty good as a general neurologist. But I think the lesson I learned from this case, and I try to keep it in mind all the time, is that when I hear about a very asymmetrical sensory problem, including pain and numbness, it could be in the distribution of a nerve, and I just don't know what nerve that is. And obviously these days you can look that up in a second on the internet, or you could get the opinion of a neuromuscular expert. I found it very interesting that the neuromuscular expert really instantly recognized this, had no trouble recognizing this as an iliohypogastric nerve entrapment. And I have to be honest, that did not occur to me. I did not imagine that that's what this was. So it was a lovely solution. The guy was cured, and that was the end of the problem. So any remarks from either Deepak or Norty before we go on with the next case?
Well, I think that was really wise of you to get the consultation. Honestly, I think if I'd seen that case, that initial battery of tests came back normal, I would have just thought, look, it's just one of those aches and pains that we don't have an explanation for. You're just going to have to live with it. But yeah, it's a good thing you went that extra step.
It's funny, the patient was a doctor. I didn't say this. And he was a colleague of mine. And he said that this pain was really wrecking his life. I mean, he couldn't jog. He couldn't do things that he wanted to do. And it was really severe. It wasn't one of these things you could sort of blow off. Anyway, I thought it was a very interesting case. And there's a couple of really important lessons in peripheral neurology, which is that the nerves are complicated. Nobody was that smart to know all these things. And just keep it in mind. If you see an asymmetrical sensory loss, numbness, think to yourself, I wonder if that's a nerve entrapment of some kind. So, Norty, you want to do your case? You have a lovely and interesting one.
This is a 37-year-old woman who was worked up extensively at the Mass General Hospital. She had seen 4 different physicians for a constellation of illness features that included fever, chills, nausea, fatigue, abdominal pain, and diarrhea for a year and a half. The physician's workups were recorded as unremarkable, nothing obvious except that she had flushing. And she had an extensive workup. Slide, please. So this is a corporealogram. That's my slang for total body workup. Cultures of blood and stool, HIV, Lyme, CMV, hepatitis markers, TSH, serum tryptase, ACTH stimulation test, urine catecholamines, urine 5-HI, comprehensive metabolic profile 20, SED rate, CRP, her ANA was positive, C1 esterase, tissue transglutaminase antibody, SSA and SSB, Sjogren's syndrome, octreotide scan, all negative. Next slide, please. She also had, next slide, she had extensive imaging, head CT, head MRI, abdominal MRI, chest CT, cardiac stress echo, endoscopy. She had a normal EGD, but she also, interestingly, in retrospect, got a little hypotensive after EGD, and I'll comment about that later. So she was referred to me. Next slide, please. And the history that I got was a little bit more inclusive. Flushing, headaches, sweats, forgetfulness, mental fog, belly pain and distension, inordinate fatigue, alcohol intolerance. She got red skin after a hot shower, and not coincidentally, she also had POTS syndrome, which had been previously diagnosed. That stands for postural orthostatic tachycardia syndrome, and she'd been on treatment for that with 2 to 4 liters of fluid a day and extra salt. Next slide, please. So on physical exam, the thing that I noticed that was striking was that she had a mantle flush. That is, her skin was red from the clavicles up. When I took my index finger and I rubbed between her scapula, there was a red wheal, and that's because she had increased histamine in her skin. 5% of all normal people have dermatographism. 95% of people with a mast cell disease have dermatographism. The remainder of her physical exam was unremarkable. My impression when I saw her was that she had mast cell activation syndrome, which I'll talk about in a minute or two. Next slide, please. So I redid the orthostatics. I had her baseline pulse at 78. When I stood her up for 3 minutes, her pulse went up over 30 to 116, and that's in the presence of her fluid loading and salt. Next slide, please. So she was put on because I thought she had mast cell activation syndrome, an H1 blocker, loratadine, an H2 blocker, ranitidine, a leukotriene inhibitor, Singulair, and a mast cell stabilizer, cromolyn. Next slide, please. So when I saw her a year later, there was dramatic improvement, flushing better, headaches better, sweats minimal, still had some mental fog, had persistent inordinate fatigue, had abdominal pain that was minimal, no diarrhea, and she had noted that certain things cause the release of histamine mediators, menses, heat, exercise, and stress, and all of that accentuated her symptoms. Next slide, please. So this summarizes what we know about mast cell activation syndrome. In the last 2 years, my colleagues at the Brigham and I have seen over 100 patients with this disorder. So it's important to make the diagnosis because in this case, proper treatment rendered the patient markedly improved. So in the history, unexplained flushing and a mantle distribution. They can't drink alcohol without getting symptoms. They get symptoms triggered by aspirin, NSAID, and opiates, and also surgical procedures and endoscopy procedures, exposure to hot and cold temperatures, belly pain with and without diarrhea, additional history of import, headaches, sweating, inability to concentrate, irritability, difficulty expressing themselves, and mood changes. On physical exam, dermatographism, flushing, and abdominal pain. That triad, dermatographism, flushing, and a mantle distribution and abdominal pain is present in 95% of patients who have this particular disorder. The lab studies that are done include serum tryptase, urine histamine, and prostaglandin D2F2. And importantly, I will reemphasize, this diagnosis is important because the patients respond dramatically to treatment with H1 and H2 blockers, cromolyn, and Singulair.
So, Norty, can I ask you a couple of questions about this? It's a fascinating group of disorders, much more common probably than we had thought in the past. I was sort of thinking as you were going along before the dermatographia in particular, I was wondering, could it be erythromelalgia? Could it be a serotonin syndrome? Could it be a pheo? How would you, clinically, how would you separate it from those other disorders?
It's interesting that you mentioned that because her previous doctors had thought about a feel and measured urine catechols. I think it's the constellation, the diagnostic triad that I alluded to earlier. Dermatographism, belly pain, and flushing in a mantle distribution, not elsewhere. So those three things should prompt an examination as to whether these other findings, both typical and additional symptoms, are present. But if the other person that had seen her, one of the doctors thought she had a carcinoid syndrome because of the flushing and the alcohol intolerance, and that was a pretty natural thing to think about, and I didn't show it, but her 5-HA levels were normal.
Is this thing, are these neoplasms, these mast cell diseases, or is this, what causes the mast cell activation, do you know?
Mast cell activation syndrome is one of about 10 mast cell-related disorders, which range from mast cell disorder with bone marrow involvement, hepatosplenomegaly, lymphadenopathy. The mast cell activation syndrome is caused by an exaggerated release of mast cell products without evidence of any structural disease elsewhere. Biopsies of the GI tract may or may not reveal an increased number of mast cells. But this is different than systemic mastocytosis or mast cell leukemia. It's in the spectrum of mast cell disorders.
So, I mean, will some of these be differentiated into mastocytosis or not, or is it completely separate?
I think the things that people think about with flushing and abdominal pain are carcinoid syndrome and pheochromocytoma, particularly if there are paroxysms of blood pressure elevation. In these patients, if they have a surgical procedure or if they have anything like an endoscopy, which will activate their mast cells, they get hypotensive. So that's another reason to think about the diagnosis. It's this particular constellation of features that I've summarized on this slide that should point one in the right direction and have them check a serum tryptase, a urine prostaglandin D2F2, and N-methylhistamine.
Are those the gold standards? I mean, is that are those the diagnostic tests that are enough? Are they specific enough for this to say that this is the disorder? Or is there a biopsy required, or what?
In mast cell activation syndrome, in contrast to systemic mastocytosis, people can have these symptoms and have systemic mastocytosis, where the biopsies will reveal a very large number of mast cells, 100 or 200 per high-power field. In this particular disorder, in all the patients we biopsied, there has not been a demonstration of increased mast cells in the biopsies. So the three things that I mentioned, the tryptase, the urine histamine, and prostaglandin, those are elevated in mast cell activation syndrome. They're not elevated in pheochromocytoma, carcinoid syndrome, and other metabolic disorders.
What about a skin biopsy?
Sorry to interrupt
skin biopsy
I see that one of our attendees, Dr. Vargo, has his hand up to ask a question, and I think for tonight we might go ahead and just open up the line. So, Dr. Vargo, you've been unmuted if you wanted to ask your question here. James, would we unmute Dr. Vargo, please?
I thought I did.
Dr. Vargo? Can you hear it? All right, sorry about that. Apparently we can't get him unmuted. We'll try again at the end.
Well, if Dr. Vargo doesn't have a question, actually I do. What do we do if we encounter a patient where we know that this is in their history and that patient, let's say this woman needs surgery in a month. Is there anything special we need to do or tell the anesthesiologist or surgeon?
Absolutely very important. For a surgical procedure, they need treatment with a mast cell products for H1 blockade, which is Benadryl and related products, H2 blockade, ranitidine, a short course of and steroids, 1 hour, 12 hours, and 1 hour before any procedure. So, for example, if a patient required a cardiac catheterization or an invasive procedure, there's a protocol where they will get 3 or 4 drugs 12 hours before and 1 hour before.
Is it just uncomfortable, Norty, or is it potentially life-threatening and dangerous, these attacks?
They can get hypotensive, and they can get 30% of these, 20 to 30% of these people have had anaphylaxis. So that's something else to be very, very aware of in these patients. They have a high incidence of anaphylaxis, and 30% of them have POTS syndrome. So if you have a patient with POTS syndrome who's having some of these funny symptoms, you need to think about a mast cell activation syndrome.
Okay.
Yeah, it's something we thought. Go ahead, Kelly.
Sorry, Marty, I think we have him unmuted now.
Yes, I'm here. I'm sorry. Dr. Greenberger, was the serum tryptase normal in this patient? I thought I saw that on the first slide.
The serum tryptase will be normal if they're not having symptoms. If it's done baseline, it will be normal. Having acute abdominal pain, they're in the emergency room, the serum tryptase is usually elevated.
So I've had a case, I had a patient, same syndrome. Patient was a runner, a college runner, had developed abdominal pain, had 2 exploratory laparotomies, and then had come to us because it had recurrent pain. So it's very similar to your presentation. A young, healthy athlete with unexplained abdominal pain. We didn't have the dermatographia, but this turned out to be one of those cases too. So this is a very nice case.
Thank you.
That's very interesting, really. I was going to say to you, Norty, last question, then I want to turn to Deepak for his case. And if you biopsy the skin where the dermatographia occurs, is it characteristic? Can you see mast cell infiltration?
Yes.
You can. Is it diagnostic?
Not necessarily, because if I took you and rubbed the skin of your back and made you get red over there, and I then biopsied that, I might see mast cells. If you see less than 20 or less, it's really not significant. If you see 50 or more, it is.
So what category of illness would you think of this as? I mean, is this an inflammatory disease, a neoplastic illness? What is it?
It's a mediator-related disease related to the products that mast cells make. And mast cells are the new rage, because we now know that there are several disorders other than mast cell disease per se where they're important, like in inflammatory bowel disease, regional enteritis, for example.
Right. Well, that's great, Norty. What a great case. Let's turn to Deepak and have him present his case.
Terrific. Those really were 2 wonderful cases. So this is a case of abdominal pain in a postoperative vascular surgery patient. So if you could go on to the next slide, please. Okay, good. So this is a 78-year-old male with abdominal pain post-op day number 2 after a right-sided fem pop, which was done for rest pain in his right foot. Relevant factors in his past medical history: he's had hypertension for 30 years, diabetes diagnosed 20 years ago, he's a former smoker, he quit 10 years ago and had a greater than 50 pack year history. You've got COPD diagnosed for the past 10 years, and he has peripheral artery disease, right foot pain at rest, as I mentioned, and had extensive workup of that pre-op, of course. Was found to have a long occlusion of his right SFA, the superficial femoral artery, with poor collateralization, and was referred for a fem-pop bypass. His medications were aspirin 81 milligrams a day, metformin 1,000 milligrams twice a day, ramipril 5 milligrams daily, extended release metoprolol 100 milligrams daily, and it was recently increased from 50 milligrams because he was going to be undergoing this vascular surgery procedure. His referring physician had done that. He's on hydrochlorothiazide 25 milligrams daily, simvastatin 20 milligrams daily. He did have some inhalers prescribed for his COPD. I didn't remember exactly what and wasn't taking them, and he has no known drug allergies. Relevant social history: he's married, 2 grown children, he's a retired engineer. The smoking history was, as I noted above, and occasional alcohol. So as far as his operative course, he underwent general anesthesia. There was an episode of transient hypotension, but otherwise it was an unremarkable operative course. On post-op day number 2, he was doing well from a vascular surgery perspective. He'd been extubated. He was on room air with an O2 stat of 92%. His blood pressure was 90/50. His heart rate was 50. Respirations 14. Temperature 99.2. He complained of nausea, and there was 1 episode of emesis associated with that. His review of systems was positive for abdominal pain, and his exam at that time was notable for decreased breath sounds, though he wasn't wheezing. He had no murmurs. He did have positive bowel sounds. He had mild right upper quadrant tenderness on deep palpation. He had no peripheral edema. He did have a moderate-sized hematoma at the right femoral arteriotomy site with moderate tenderness at the area of that hematoma. Based on that, blood cultures were sent. An ultrasound of the gallbladder was ordered. Antiemetics were ordered, and he did have relief with that. Morphine was ordered for pain from the hematoma. His systolic blood pressure after all of this was running in the 85 to 90 range post the morphine and antiemetics. His heart rate at the time was 45 to 50 or so. And he was felt to have had a vagal reaction from some abdominal pain and maybe from the hematoma. And in response to that, 500 cc normal saline bolus was ordered ×2. And then, as I mentioned, an ultrasound of the gallbladder had been ordered and ended up getting done as well. And that showed thickened gallbladder walls and slight distension of the gallbladder. His systolic blood pressure post-bolus was in the low 80s. And Kelly, let's stop here and not advance the slide. But his abdominal discomfort persisted. And the thought at the time was he was somebody that went through perhaps not the most major vascular surgery. The peritoneal cavity wasn't invaded. It was surgery that potentially could have been done with spinal anesthesia, for example. But, he did get general anesthesia, and the thought was he was someone that had had a major procedure, and the diagnosis of acalculous cholecystitis was thrown out there. What do you think, Dr. Greenberger? Is that something that's reasonable to consider here?
It's reasonable to consider, but those patients are usually sicker. The other thing is he's a diabetic, so he's entitled to have mesenteric vascular disease. He does have gallbladder disease, which can account for some of the problem. And one of the things that happens in diabetics who are not well controlled is they get gastroparesis, which gives them epigastric pain and discomfort, which can be rather severe.
And in terms of gastroparesis in this diabetic, he did have diabetes for a while, and in fact may have had it longer than it was diagnosed, as is often the case. But he was just on metformin twice a day. Is that bad enough diabetes to have gastroparesis?
It relates to their hemoglobin A1C. If I took you and raised your blood sugar to 200 and higher, I could make your stomach stop working. I can stop your antral motility. So even though they're on medication, it's a question of what the control is. You can check for gastroparesis by doing a simple thing at the bedside. Take your stethoscope out. If the patient hasn't eaten for 12 hours, shake them and see if you hear a succussion splash. If you hear a succussion splash, you know you have prima facie evidence. You don't need a nuclear medicine gastric emptying study to diagnose gastroparesis.
Yeah. This guy was not on DIG, is that right? DIG was not part of his medication regimen, is that correct?
Yeah, that's correct. He wasn't on digoxin, did not have any known heart failure.
I mean, to me, this, again, here's a neurologist talking, but to me, this sounds like mesenteric ischemia. And he's got a number of risk factors for it. And even though his abdomen was not invaded, I think this is a circumstance in which it's possible or likely that was the case. Did he? Was he having stools, and was it guaiac positive?
He hadn't had any bowel movement. He was passing gas, and he was at one point a little bit later on guaiac, and was guaiac negative. Rectal exam was non-tender.
Yeah, I would be concerned about mesenteric ischemia. I don't know how you feel about that, Norty, but it seems to me that with this story in this context, I'd be worried about mesenteric ischemia.
You're quite right, and when you have abdominal pain that is disproportionate to what you can find on physical examination, think about that. The only other thing that comes up here is that cardiac disease can also give you abdominal pain, and one of the rules for all cardiologists is that they have to think about cardiac causes in people that have inexplicable or poorly defined abdominal pain.
Yeah. Inferior ischemia particularly, isn't that right, Deepak? Where people get abdominal pain sometimes.
Yeah, that's something always worth considering. Inferior ischemia is notorious for manifesting as abdominal pain. So here he actually did also have some tenderness, so it wasn't just a subjective sense of abdominal discomfort, but tenderness, and it was, at the time, it seemed to be localized to the right upper quadrant. Does the fact that he was quiac negative move us away at all from mesenteric ischemia? That is, those folks.
Personally, my view about that is that that would have been useful as positive, but I think the fact that it was negative does not help me. I don't know how Norty feels about that. You're the expert.
If you have acute mesenteric occlusion and you have a catastrophe occurring in the abdomen, you are going to get Hemoccult positive stools and bleeding. But if you have incipient occlusion and infarction, you may not have Hemoccult positive stools, so the absence of does not dissuade one from the consideration of a mesenteric ischemia.
And, you know, in this situation, a lot of times, it wasn't done here, but I've seen a lactic acid drawn when there's just even a consideration of mesenteric ischemia.
That's a very good thing to do, because if they have impending infarction, that's going to be positive. In people that have chronic mesenteric ischemia, for example, mesenteric venous disease, that will not be elevated, but in the case of impending infarction, that's usually elevated. And it's always elevated if they've already had an infarcted gut.
Mm-hmm. Right, so this is, again, one of these tests that would be useful if positive, right, Norty?
Right.
Well, you know, the two of you have good instincts. I must say, at the time, you know, I guess there was a bit of anchoring. That is, someone had thrown out the diagnosis of acalculous cholecystitis, and even though it's true the patient in truth wasn't that ill, I guess we sort of constructed a story for ourselves that he had major surgery, he had general anesthesia, and sure, he could have acalculous cholecystitis. But could I get the next slide, please? But in thinking about things, an ECG was also recommended. That showed sinus bradycardia at 48. A surgical intern reading that didn't note any ST elevation, but knew to look for that, realizing that inferior ischemia could be the cause. Also wisely sent cardiac biomarkers at that point. A little time passed, and those returned with a positive troponin. An ECG was repeated at that point, and in fact showed 2 to 3 millimeters of ST depression in the inferior leads. And in fact, on re-review, the prior ECG from earlier had also shown 1 millimeter or so of ST depression in the inferior leads. It was a bit subtle, and really at the time it was ST elevation that was being sought, but in fact ST depression was present. Cardiology was consulted, and the patient was ultimately taken to the cath lab, and there an angiogram revealed a 95% stenosis of the mid-right coronary artery. That was prior to a large right ventricular marginal branch, and that lesion was successfully stented.
Very interesting.
Next slide, please. So the key lessons here, and we touched upon a couple of them. I gotta say it's pretty good that a neurologist and a gastroenterologist both nailed the diagnosis here. And the lessons are that ischemia can manifest as abdominal discomfort, and that's more classic for inferior or RCA ischemia, though sometimes even other distributions, such as a dominant left circumflex that serves the same territory, can cause such symptoms. Additionally, ischemia can cause hypotension and bradycardia. Any big infarct can cause hypotension, of course. A big LAD infarct can cause hypotension. But the fact that there was also bradycardia with the hypotension might lead one to think more of inferior ischemia. Of course, that might be a little bit more complicated in this man who was on beta blockers, who also had his beta blockers recently increased preoperatively, and it could be the case that that would mask some degree of tachycardia, but it certainly shouldn't make him bradycardic. RV ischemia can be profound and refractory to initial fluid resuscitation, so that's something to remember. With a right coronary artery infarct, if the right ventricle is also involved, that can manifest as profound hypotension. Those people can take liters and liters of fluid before their hypotension resolves, and it may not resolve until they're revascularized and get sufficient fluid challenges. And finally, just to always be wary of postoperative ischemia, especially in patients at high cardiovascular risk, such as this gentleman, even if they were, and I put this in quotes, cleared for surgery, because of course, in cardiology or internal medicine, we're never clearing a patient for surgery, we're just risk stratifying them.
Right.
I think that's a very instructive case. I think that, just to reiterate, one of the neurological points of cardiac innervation, we think of the heart as mainly being in the T1 distribution, that is to say radiating down the inner part of the upper arm, and that's true for most left ventricular infarcts. The fact is that cardiac innervation from a sensory standpoint goes all the way from T1 to about T8 or so. Remember, T10 is the umbilicus. So pain in the epigastrium is not at all rare with inferior ischemia. So again, an example of referred pain, a little bit like the first case where we had the entrapment of the iliohypogastric nerve, and it sounded like renal disease. So actually, we've had two cases which have sort of made a similar point about referred pain. Very interesting. Norton, do you have any points to make about this one? We're running just about out of time, but I wonder if there's any final comments you want to make about this case.
No, I think that it unfolded in a very illuminating way, and it was a useful reminder that all pain in the belly does not necessarily originate from the viscera. You have to think about cardiac causes.
That's great. Well, I think this has been an absolutely interesting, unusual approach to abdominal pain, not the usual thing. We've seen, I think, three very interesting cases. You can see what the pitfalls were in our thinking about these. And we really appreciate John Vargo's input, telling us about his case, which is really one of the functions of this kind of an endeavor. And with about 1.5 minutes left, I'm going to turn it back to Kelly and let her bring it to a close.
All right, thanks, Marty. Yep, we are just about finished now. We're almost at 45 minutes, and I do want to be respectful of everyone's time, so we're going to go ahead and wrap this up. Please remember to complete the survey that I'm going to be putting up on your screen now. If you would like any of the information that we referenced in the webinar, including information on getting the 0.75 CME credit for attending. And just so you know, we do have a library of archived webinars on topics just like this one, such as fatigue, low back pain, and headaches. And you can watch this webinar and all archived webinars at bestdoctors.com/physicians. So be sure to check those out. And I'd just like to thank our fantastic panel for a great discussion, and thank each of you for coming. And we hope to see you next time.
Wonderful. Thank you all. Thanks very much, guys.
Thank you.
Thank you.
Good night.